Good afternoon all, I am Dr. Brindha. I like to thank AIOCMTC Scientific Committee for selecting my work as the best paper of the external IDC session which happened last year AIOC's midterm conference. And I like to thank my mentors Dr. Geeta Behra and Dr. Ramesh Babu sir. I'll be addressing my paper on evaluation of dry eye in rheumatoid arthritis and systemic lupus erythematosus and its association with anti-SSA and SSB autoantibodies. Dry eye is a multifactorial disease and the ocular surface is maintained by the tight immune regulation which fights exogenous and endogenous pathogens while maintaining tolerance to the self-antigens. In autoimmune diseases like SLE and RA, this regulation is broken by the multiple triggers which results in aberrant activation of the immune system. As we already know, anti-SSA, SSB autoantibodies are associated with the primary Sjogren syndrome, dry eye. In secondary Sjogren syndrome in SLE and RA, the proposed pathology is impaired tear production because of the lymphocytic infiltration by the self-reactive immune T cells. My study aim was to estimate the prevalence and association of the dry eye with anti-SSA, SSB autoantibodies in the rheumatoid arthritis and SLE patients. We included patients above 18 years of age with rheumatoid arthritis according to ACR-Euler 2010 criteria or systemic lupus erythematosus according to ACR-SLIC 2012 criteria. We included 90 rheumatoid arthritis patients and 55 SLE patients and excluded patients with active keratitis, conjunctivitis, Stevens-Johnson syndrome, cicatricial pemphigoid, lacrimal gland malignancies and sarcoidosis. In the methodology, we documented the duration of the disease. Disease activity was calculated using DAS-28 for rheumatoid arthritis and SLE disease activity index for SLE patients. Self-reported dry eye symptoms were noted, topical and systemic medications were noted, and anterior posterior segment examination was done. All patients were subjected to dry eye questionnaire of both OSDA and SPEED and objective dry eye test which included the Schimmer's test, ocular surface staining where we done both SICA OSS staining and National Eye Institute staining score. Tear film breakup time with fluorescein was done and all patients were subjected to serology for ELISA of the anti-SSA SSB autoantibodies. Coming to the results, in the rheumatoid arthritis group the mean age was 44 years and in the SLE it was a decade younger, 32 years. And in both groups the female predominance was noted and mean duration of disease was 6 years in rheumatoid arthritis and 7 years in SLE. In both the groups, the majority of the population were in remission or low disease activity. Self-reported symptoms was noted in 35% of RA patients. With the questionnaire, SPEED was able to detect more dry eye, which was 57.8%. So SPEED scores were more than the OSDA. This discrepancy was because some of the questions in OSDA were not applicable to the Indian setting. The similar pattern was noted in the SLE. The SPEED questionnaire was more effective. And when comparing between RA and SLE, RA patients were more symptomatic than SLE. Coming to the dry eye prevalence, in both the groups, the tear film quality was affected more than the quantity, indicating that the subclinical dry eye disease is more prevalent than the symptomatic dry eye. Even though 35% of RA and 25% of SLE patients were symptomatic, less than 5% were previously diagnosed with dry eye and were on treatment. This highlights the need for vigilant screening of dry eye irrespective of the symptoms, disease activity and duration. And the relation of the disease duration and activity, there was no significant association with the disease duration because the patients were already on treatment as the median duration was 6 years. And coming to the disease activity, the majority were in the remission or low disease activity. Even though they were in the remission phase, their tear film quality was affected. They had abnormal T-beauty and staining scores. This suggests a subclinical dry eye disease in the minimal disease activity. The similar pattern was noted in the SLE group also. Apart from the tear film quality and quantity, the anti-double-stranded DNA discoid lesions of the lid and methotrexate resulted in blepharitis, and immune complex deposition causes the meibomian gland dysfunction. So the lid examination is also as important as the tear film assessment. Coming to the anti-SSA SSB autoantibodies, in rheumatoid arthritis group, we were able to had a low detection of the autoantibody level and they had no association with the dry eye. In the SLE group, 31% were positive for SSA antibodies, of which majority of them had a poor tear film quality. Coming to the discussion, among the patients of RA and SLE, the abnormal staining scores and tear film breakup time scores were comparatively higher to the abnormal Schimmer scores. This indicates that the ocular surface inflammation is the major pathology than the decreased tear production, and there is no significant association with the SSA SSB autoantibodies. So the anatomical target is ocular surface epithelium more than the lacrimal gland, the suggested pathology being increased pro-inflammatory cytokines at the level of ocular surface. So secondary Sjogren syndrome with a decreased tear production causing dry eye could be a minor mechanism in the rheumatoid arthritis and SLE patients. The postulated dry eye pathways could be multiple risk factors causing autoreactive T cells or impaired neutrophil extracellular trap formation clearance, or increased cytokine production by the activated Langerhans corneal cells, all of which causing the local ocular surface inflammation resulting in dry eye. The strength of my study was, it is the first study to report dry eye in both SLE and RA Indian patients, and this is the first study to utilize two subjective dry eye questionnaires, OSDA and SPEED, and demonstrating SPEED has a greater applicability in our Indian setting. And the limitation was we did not look for tear film hyperosmolarity, and in our study the majority of them were in remission or low disease activity. Only few patients were having severe disease, so we were not able to comment accurately on the association with the dry eye. So dry eye in SLE and RA has no association with the SSA, SSB autoantibodies, disease duration and activity. Subclinical dry eye is more prevalent, and the recommendations are vigilant screening is required, and the order of assessment should be symptom assessment with the SPEED questionnaire even if the patient is asymptomatic, and tear film quality assessment with the staining and fluorescein tear film breakup time, which is imperative, and tear film quantity should be the third, and last but not the least, lid examination should be important. These are my references, and thank you.